Welcome to the Practice of Medicine podcast from the Southern Medical Association. Since 1906, SMA has had a singular mission: to provide medical professionals with the resources they need to learn from each other, and in doing so, to improve the overall quality of patient care. The Practice of Medicine podcast is just one of the ways we do that, as we discuss a wide range of topics, including the Physicians in Training Day in the Life podcast series. To learn more about SMA's many other services and educational initiatives, please visit us at sma.org. Today, we are again joined by Drs. Jason Wagner and Richard Holt. We spoke with each of them last year as the pandemic began. Dr. Wagner highlighted the clinical features of critically ill patients with COVID-19 and discussed the various treatment approaches and future challenges, while Dr. Holt examined the public health and ethical issues associated with the current novel coronavirus infections. In this podcast, they will look back on the past year and discuss the effects of the pandemic on clinical outpatient care and how physicians have been coping, as well as insight into the medical profession's response to the pandemic and ethical issues in patient care that may have arisen as a result of COVID-19. Thank you so much for being here.
Our pleasure.
Thank you for having me.
Dr. Holt, let's begin with you. How well have physicians coped personally with the pandemic over the past year?
Ms. Price, thank you for that question. It really is a very pertinent question. The short answer is to varying degrees, I think, although it started off very difficult for most physicians to cope. I think it ended relatively well at the end of 2020, in spite of some of the surges and so forth. I would have to say that in my 50 years of being a physician, I have not seen the challenge to the medical profession such as we saw during the pandemic. Coping, as you know, is a progressive thing. Some people are obviously better at coping with this sort of challenge than others. But for a profession that was already stressed for so many reasons and where burnout was so high, I believe we could have expected some worsening of that, particularly in the early phases. There were so many things to worry about for physicians, particularly early on. Can I keep my practice going? Even in academic medicine, it was a challenge. Can I protect myself and my family members if I am exposed to COVID by the care of patients who are ill? What about my patients? How are they going to be able to get care? Can I manage to provide good care for them as I have in the past, or is it going to be compromised? I don't believe anybody exactly knew the extent of the challenges and how the coping mechanism might work. But I do believe everybody wanted to do the right thing for themselves, the patients, the staff, society, and so forth. So it really did bring out the resilience in physicians and the patience, I would say, in trying certain things almost empirically and seeing how they worked in inpatient and outpatient care of patients. And I will say there was a lot of hope and faith that came to bear in most physicians' lives in dealing with the challenges that were there. I was very impressed with the collegiality that physicians gave to each other. In fact, I was worried that there might be some siloing effect where physicians would indeed pay more attention to themselves and not as much to helping other physicians. But I did not see that, at least in my small realm of practice. I believe everybody was trying to do the right thing and to be cognizant of issues they might see in their colleagues and help them out in some manner. In the end, I believe it was a lot of moral courage that physicians had to exhibit And I do believe, for the most part, they exhibited good moral courage.
It has definitely been an interesting year that I don't know that anyone could have seen coming. And I have to agree with everything you've said, just to see how the physicians and the healthcare professionals have risen to this challenge that we've never seen anything like before. Dr. Wagner, over the past year, how has your thinking evolved when thinking about treating hospitalized patients with COVID-19?
I take that one. My pleasure to have that question. I agree with everything that Dr. Holt said about resiliency, and sometimes it felt like drinking hard from a fire hose. It's hard to know if you're doing a good job doing that or not. But I think in retrospect, we're going to be proud of ourselves, although quite tired. I would say the evidence has evolved somewhat with regard to the treatment of severe COVID-19 patients, specifically with reference to ICU patients. There was a little more clarity, I would say, with regard to using steroids and helping to try to save some lives in those folks that have severe disease. We have, focused on that to quite a bit. Um, Back when we spoke, I think there was a lot of empiricism, as Dr. Holt alluded to, of trying all sorts of stuff in our kitchen cabinets, stuff in our medicine chest, anything and everything, existing drugs, looking for some curative effect of COVID-19. And at this point, outside of a vaccine, I would say there's no cure here. It's about minimizing damage with regard to hospitalizations. So dexamethasone or steroids, I think most folks are using at this point, and can bank on some pretty high quality randomized clinical trial evidence for that. Just recently, a study came out of the UK looking at tocilizumab. It's not in widespread use here. IDSA has not recommended it, at least as I'm aware of today, to start using that, but that could be something that we're seeing in the near future. This again is to mitigate the immune response to COVID-19. There has been a little bit more clarity with regard to anticoagulation and how to address the increased risk of thromboembolism that COVID-19 imposes on many people. So most of us are very aggressive with using chemical prophylaxis for anticoagulation, and in some patients, we're therapeutically anticoagulating them based on individual clinical risk factors. Um, to be honest with you, outside of those things, what is more often taking place, I would say, is a slow regression from using things that are now a little bit clearer that don't necessarily help. So, for an example of that, I would look at convalescent plasma. This is plasma obtained from individuals who have had COVID-19 and developed antibodies. In the early days, if you will, which is just a few months ago, it was in pretty widespread use in many places to try and help bolster one's immune response to COVID-19, be more specific. I would say that now most of the data to support its use is in individuals who have um, mild disease for just a few days. So the study that supports it is just about 3 days worth of symptoms in individuals who aren't on oxygen. I don't meet many of those folks in the ICU. So by the time folks get to the ICU, we're trying to de-adopt, if you will, many of these things. And I think plasma is one of those things. Outside of those, most of what we're doing in the ICU is just trying to remain a high quality evidence based approach with regard to sedation, mechanical ventilation, early physical therapy. And I think the most challenging aspect of managing folks with COVID is the reality of the capacity strain that is existing when you're trying to do so. It's one thing to take care of a critically ill patient on a ventilator. It's a different thing to try to take care of 12 of them simultaneously or 20 of them. And so when you have lots of folks coming into the ICU, at the same time with high severity of illness. The thing that I worry about that keeps me up at night, am I missing the small things that I know work already as we try all these experimental things? Am I missing the things that I know work? And that can be somewhat fatiguing on a daily basis. But I would say that that's kind of where we are with the state of things.
Dr. Holt, Dr. Wagner has provided some insight into caring for the patients from the clinical side. I would be interested to know, have there been any unforeseen or unusual ethical issues in patient care? And if so, how have those been managed?
I hope Dr. Wagner will add to this to these comments that I'm going to bring forward, because he was facing and still faces a number of ethical issues that are life and death in nature. I think none of us had really seen this sort of challenge to ethical care of patients in this regard. And so many of or in fact, maybe most of the ethical issues that came up were new or some unusual variation of ethical concerns that we all have in caring for patients. From the standpoint of my specialty in otolaryngology, head and neck surgery, we, like Dr. Wagner, who's a pulmonary critical care physician, are in the patient's airway. And so since COVID was primarily spread by aerosol generated actions, and he and I both do flexible scoping of patients, and we really can't examine our patients well without being in their airway. Our two specialties were really at high risk, and not just for us, but also for our staff who had to be present with and helping us and cleaning up after us. We had to evaluate the air clearance rates in all of our examination rooms to determine how long we would have to have that room sit empty with air exchange before we could put another patient in there. Because we just couldn't risk other patients being exposed to somebody who may have COVID. And early on, we really didn't have a good way to determine if they were exposed or carrying COVID or even had COVID themselves. We were able later on to have a COVID test before we actually did a procedure such as a tracheotomy change or flexible scoping to try to reduce the risk to the staff primarily. That sort of segues into another ethical issue that was pretty widespread across the U.S., namely that hospitals did not have adequate personal protective equipment for the staff in the event of this sort of thing. I don't know where the problem was and why it happened, but it seemed to take an inordinate amount of time to get the adequate equipment. It took us in our specialty, along with oral surgery and anesthesia, a fair amount of time to convince some hospital administrators that we should have PAPRs for surgical procedures of kind of high risk. So weeks went by before some of the best equipment was actually purchased and made available. I really think it was an ethical concern and an ethical challenge to send people into exam rooms, into rooms with patients with COVID, with perhaps inadequate training, inadequate PPE. And that was an ethical issue that the whole healthcare industry and medical profession actually had to deal with. So number one, the patients needed to be kept safe. And I think everybody tried to do their best, but because of the lack of supplies, it became a real ethical concern, I think, for everybody. Another issue we had in my specialty was the difficulty in doing surgery safely. At first we didn't have any triage protocols, so we developed protocols based on the military triage system, which works pretty well for trauma and so forth, but not for other kinds of illnesses. So in our department, we had a small COVID protocol committee that looked at the evidence that was available and ongoing evidence to determine how do we triage, how do we manage the risk versus the care for the patient. And I consider those to be ethical things. We were able to prioritize the patients who needed emergent surgery. Some were obvious, such as trauma patients, but others perhaps not so obvious. And that included in my specialty head and neck cancer patients who needed to have surgery for removal of their cancers in a timely manner. Before we really had good Zoom calls, there was not a good tumor board meeting protocol for these patients. And it was hard to get hold of consultants to help in making decisions about how to treat these patients in a timely manner. And even worse, the patients had difficult time getting hold of some of their doctors and to have meaningful discussions or meaningful treatment options that they could talk about. And that's also a segue into how effective the virtual discussions with patients really became. Started off not really very good, at least in our specialty, because a lot of our patients here in San Antonio, particularly, don't have access to some of the little higher definition iPads and computer programs. We would oftentimes be lucky if we could get in touch with them by telephone. And since so many of our patients speak various languages, it was hard getting translators to do a three-way with the patient. We really needed to see the patients. And so when we were able to have a video virtual examination, that worked pretty well. But if we were not able to, it was very difficult to try to discuss things with them using a translator if we were able to get a translator. So those are just a few of the ethical issues, and I really hope Dr. Wagner can bring up some of his.
Yeah, I would echo all of those. I think that from a provider standpoint, you can never prove safety, but you can strive toward it. And I think, knowing that you have the necessary equipment to do your job as safe as possible, I think can not only make you safer, but also less fatigued when you're going through a busy day, when you feel like the things are in place. And I think in my specific area where I'm working, I think folks did a pretty good job with that. And so I was appreciative of feeling like, for the most part, I had what I needed to do my job well. The logistical challenges that imposes, it's along the entire healthcare spectrum. In our clinic, is it safe to do pulmonary function tests? Does a negative COVID test 2 days before mean the person who's going to do pulmonary function tests 2 days later have COVID-19 or not? Who can safely come in for a clinic visit? Is it appropriate to tell someone they have a new diagnosis of lung cancer over a Zoom meeting? Am I able to provide the same bedside manner that I could in person as opposed to telemedicine? So I think, in many regards, people suffer from COVID, but they also suffer because of COVID. folks who do not have COVID but can't access care efficiently are suffering because of COVID, for example. In the ICU, I think one of the things that's most distressing is the social isolation that COVID patients have, and how that can necessarily or potentially affect goals of care conversations. When should we consider transitioning to comfort-based care if all of my conversations are happening over the telephone? I never meet folks in person, family members, surrogate decision makers. It's hard to build trust over a telephone. It's much easier to do that in person. Again, reflecting on an improved bedside manner when there's actual interaction. So the social isolation thing, I think it was a real challenge. And in addition to the logistical challenge that imposes on, eliciting what the right thing to do is for a patient on a ventilator per se, it also meant that we felt morally obligated to be there for patients when they were dying. And usually that would be done by a loved one if there was one present. And so I think that ethical, moral struggle, if you will, was challenging. I often felt like, damn be the protocol. I want the person's wife to be at the bedside, for example, but that's something that was possible. Um, so I think those are the things that really stand out. And I think on a more healthcare delivery standpoint, always in the back of my mind was the crisis standard of care. Were we ever going to have to make decisions about who gets high flow nasal cannula, who gets mechanical ventilation, and who doesn't? And thankfully, in my own experience, we didn't really get to that point. But we had to prepare for it. We had to think about how to do that, how best to do that. And I think what's challenging in the ICU is that a ventilator is often viewed as a cure, but it's not. Many patients who get intubated um, don't get better, and so, but it's the last resort, if you will. And so, I always struggle. Rationing is withholding something that has a known benefit. It's not necessarily rationing to withhold uh, a healthcare device from someone who has no chance of benefiting, and and that is a very hard conversation to have over a telephone, or a very hard thing to measure accurately because it's related to prognosis. And any physician who has 100% certainty in their prognosis should check themselves. So that all plays together, I think, into some unique aspects that COVID has really brought to the surface, I think, on a prevalent manner. So
You mentioned having to maybe stand in for a loved one who couldn't be there. We here in Alabama have recently started opening up to visitors for end of life
mhm.
decisions, or when has Texas, or has that changed, or are you still having to sometimes fulfill that role? Or have the rules kind of started maybe loosening just a little? I know they are here on kind of case by case basis, where before when we spoke there, that wasn't even considered an option.
Yeah, I think for folks that are who've made the decision, for example, for their loved one to uh, transition to comfort-based care, we allow two family members at the bedside, not rotating, just two. But in a big state like this, where folks are getting transferred from other hospitals, I don't think folks in real time understand when you're getting transferred 3 hours, 4 hours away to get an ICU bed, you're being transferred away from your social support system. And so sometimes it wasn't possible, even though it was available. Sometimes things happen so quickly that there's not enough time. Uh, but we did our best to try to accommodate that. I th- I think once that decision's made, things we were clear on the ability to have that done. The harder question is, or the harder thing to accomplish, is sometimes it takes someone seeing a person, the context, in order to think more clearly about what is the best course moving forward. and that is compromised. Even when there's FaceTime capability, that's compromised.
You touched on briefly in your conversation just a moment ago about surrogate decision making. Are there any unique challenges when thinking about the greater impact of COVID when it comes to surrogate decision making, and how the family members play into that as well?
I think the two things that I that have been hardest to experience, I think one is just this inability to be at the bedside together to address the best course of action. My job is to know the evidence, know how to apply the evidence, know how to interpret the labs, the chest imaging, the ventilator, but also to make sure that all the decisions we're making are aligned with a person's values and preferences. And that's really challenging to do when that social isolation factor is occurring. The other factor is that you always have to be aware this is a pandemic, it's contagious. The person you're talking to on the other end of that phone also has COVID very commonly. A wife is in the ICU, a husband's at home, they both have COVID. It makes it very challenging in addressing things. It's a contagious disease. It's very different than talking about congestive heart failure with a loved one. Sometimes the entire household has COVID. I've had conversations where a family has already lost 3 other people. And so it becomes incredibly taxing emotionally on a family when there's an outbreak within it. And I think that undoubtedly puts a strain on a surrogate. To be able to think objectively, and then again, just to have any support at all with that it's quite tough.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcasts or subscribe to us on iTunes, Google, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org. And thank you for joining us.